Good morning. My name is Alan Bocking, and I am a professor emeritus, retired obstetrician. I was previously a high-risk pregnancy obstetrician, clinician scientist, and I worked at Western University and St. Joseph's Health Centre in London for 18 years before moving to Toronto in 2003. Where I was on faculty there and in a leadership role at Mount Sinai Hospital, as well as the University of Toronto Department of Obstetrics and Gynecology for 15 years. So I'm delighted to be able to speak with you today, and I want to thank Rob Moore and the Rural Ontario FASD Support Network. It's a wonderful organization, and I really appreciate the opportunity to talk a little bit about what I've titled here, FASD Research, how did we get to where we are today? And it's going to be a little bit of, it's really my personal perspectives. I'm going to talk a little bit about the work that I was involved in a number of years ago, and then talk a little bit about the CanFASD Research Network, which I had the privilege of being the scientific advisor for 5 years up until 2 years ago. And I currently, full disclosure, am a member of the board of directors of CanFASD Research Network. First, want to acknowledge that I'm giving this talk on the territory of the Anishinaabe Nation, in particular the people of the Three Fires, known as the Ojibwe, Odawa, and the Potawatomi nations. And also recognize the Chippewas of Saugeen and the Chippewas of Nawash, known as the Saugeen Ojibwe Nation, as the traditional keepers of the land. So in the beginning, quotes, fetal alcohol syndrome, or FAS, was first described by Jones and Smith in 1973, so almost 50 years ago. That was exemplified by some characteristic facial features, significant growth restriction, and severe neurodevelopmental delay. Would point out that at that time, I was actually just starting medical school. So there you go. It was shortly after that that Claren and Smith described children having what they described as fetal alcohol effects, or FAE, and the key factor being that in these individuals, there were no facial features, so separating that from fetal alcohol syndrome. Throughout the early 1980s, I was involved in some research looking at the initial observations of the effects of prenatal alcohol exposure, which we now call PAE, on human fetal behavior. And these studies were carried out with the late Dr. John Patrick, who is an obstetrician at Western in London, along with his colleague, Dr. James Bryan, who was a pharmacologist on faculty at Queen's University and is now a professor emeritus in the Faculty of Medicine at Queen's University. This was an amazing collaboration because they really described the effects of one dose or intravenous dose in sheep, but in human, an oral drink of what would be the equivalent of 1 to 2 drinks of alcohol, and observed the fetus using ultrasound for a number of hours following that. And strikingly, fetal breathing movements, which are movements of the fetal chest, which are not used for the fetus to obtain oxygen, but are used to help the fetus to grow the lungs and help the lungs to mature for when the baby's born. But fetal breathing movements are tightly linked to sleep states in the human fetus. And they observed that with that one drink of alcohol, that those fetal breathing movements were basically abolished for up to 9 hours. So clearly a major effect on fetal behavior. They went on and observed those same effects in chronically catheterized fetal sheep. And Dr. Bryan was able to characterize the pharmacokinetics of alcohol with exposure to the mother, and really showed that alcohol crosses the placenta very readily and goes back and forth across the placenta. The fetus actually later in gestation swallows amniotic fluid, and it goes into the circulation, and then the fetus then is able to excrete some of that alcohol through its urine, and it remains in the amniotic fluid. So the alcohol itself is not metabolized in the fetus, but actually in the maternal liver. So understanding those effects of alcohol exposure in both the human fetus as well as in the chronically catheterized sheep help to really confirm that, in fact, there are biological mechanisms relating to how alcohol in utero can alter fetal development. We showed in some studies in chronically catheterized sheep that some of the changes in fetal behavior were related temporally to changes in neuromodulators in the cerebrospinal fluid of the fetus. And those were examples were adenosine and prostaglandin E2, which is a hormone which is produced by the placenta, actually. So affects not only on the brain, but also in the placenta. Throughout the 1990s and into the early 2000s, there were multiple animal studies showing the long-term effects of chronic exposure to alcohol in utero on many systems, including the cardiovascular system, the renal system, as well as on neurodevelopment. And we now know that those effects also take place in the human, which we'll talk about in a few minutes. Throughout that time period, there were a range of diagnostic terms that were developed. And it was then in 2005 that the Canadian group, multidisciplinary group, established the Canadian Diagnostic Guidelines, and they published these. And many of you will know that they were updated again in 2016. Throughout the first 2 decades of the new millennium, there were really many studies looking at mechanisms for prenatal alcohol effects. In particular, there are a number of studies looking at the role of biomarkers, and some of you will remember the studies that were done with meconium, particularly looking at the presence of fatty acid ethyl esters, which were metabolites of alcohol in the fetus. And these were not particularly helpful in my view. There were obviously ethical concerns about performing these types of studies. Clearly, stigmatism associated that for the biological mothers, and they really didn't develop the specificity that what we want for prenatal alcohol exposure. So to my knowledge, there's not a lot of work being done on biomarkers now. There has been also a lot of work done on the epigenetics, both in the human as well as in animals. And there's a large group in Manitoba looking at epigenetics in large populations in the human. But in the animal studies, again, using rodents and also larger animals, that clearly, there are changes in epigenetics with prenatal alcohol exposure, and epigenetics refers to the ways in which gene expression can be altered without actually changing the DNA itself. And it also provides an explanation for why we see the transgenerational impact of trauma and previous generational exposure to prenatal alcohol. This was going on at the same time as a new whole body of science called the Developmental Origins of Health and Disease, or DOHAD, has developed. And this is looking at the gene-environment interactions in the first 2,000 days of life. So in utero, and then in the first few years of life. And there's a whole body of literature demonstrating that stress in utero, for example, exposure to corticosteroids, nutritional alterations, both overnutrition and undernutrition, can give rise to serious later development of health and disease. And things like hypertension, diabetes, cardiovascular disease, some of the mental health conditions such as schizophrenia. So those gene-environment interactions are critically important in terms of our, as individuals, our developmental trajectories. And in my mind, actually prenatal alcohol exposure is the penultimate example of developmental origins of health and disease. And unfortunately, due to many different reasons, which we can talk about after, the prenatal alcohol exposure has not really become a big part of that body of literature. And I think it needs to be, in my view, further enhanced into that mainstream areas. There are international societies of developmental origins of health and disease, for example. A lot of work has been done around neuroimaging and looking at connectivity, again, demonstrating in individuals with fetal alcohol spectrum disorder that there can be alterations in certain pathways connectivity. Dr. James Reynolds, who you I'm sure know well, has carried out a number of studies looking at saccadic eye movements as diagnostic tests, and this again are areas of ongoing studies. And last but not least, in Canada in particular, we have a group based at CAMH with Dr. Lana Pobova, who have done some very nice epidemiology studies throughout the world in conjunction with the World Health Organization and also locally in Toronto, demonstrating that at least in many parts of our country, the prevalence of FASD is at least 3 to 4, probably 4%. And it's not in any specific populations. It seems to be in throughout our society. So now I want to move and talk a little about CanFASD, or the Canada FASD Research Network. It was established in 2005, and it was created because the main focus of a continuing government alliance, so the 4 Western provinces, so BC, Alberta, Saskatchewan, and Manitoba, and 3 northern territories, the Yukon, Northwest Terrace, and Nunavut, had established the Canada Northwest FASD Partnership. The partnership had actually been working together since 1998 towards the development and promotion of an interjurisdictional approach to diagnosis, prevention, intervention, and care in support of individuals who are affected by FASD. So clearly, very early on, 15 years ago, 20 years ago, I'm sorry, really recognizing that the approach to helping individuals with FASD and their caregivers and those around individuals with FASD really did require an interjurisdictional approach. And I applaud those provinces for that approach. And it's a type of thing that I think that other provinces across the country can benefit from that experience. In 2012, CanFASD obtained not-for-profit status, as well as a charitable status in 2013, and really has allowed it to become nationwide. New Brunswick joined the network in 2013. Of note is that Ontario joined in 2017 for 2 years, but sadly has not renewed its membership. Something that, again, we can talk about subsequently if one wishes. But this year, the network established the individual membership option. And again, we can talk about that in the question period if people have questions about that. So broadly speaking, CanFASD research is focused on 5 major areas: prevention, diagnosis, interventions, justice, and child welfare. And there are research leads across the country in each of those areas. Clearly, I'm not going to be able to talk about all of those areas, but I would like to highlight a few. Um, First being prevention, and many of you may have already seen this or certainly be aware of the framework for addressing prevention of FASD that Dr. Nancy Poole from the Center of Excellence for Women's Health in Victoria and Vancouver has established with her group. And briefly, these include, as you can see on your left side, the level 1, which is the broad awareness building and health promotion efforts through community development. Level 2 being a discussion of alcohol use and related risks with all women of childbearing years and their support networks. Level 3, a specialized holistic support of pregnant women with alcohol and other health social problems. At level 4, postpartum support for new mothers and support for child assessment and development. And all of these around a supportive alcohol policy. So in my mind, this has allowed a very organized approach to how one can develop interventions for prevention of FASD with targeted interventions and targeted approaches to specific populations. And this has been recognized and adapted really worldwide. Many countries such as Australia have really embraced this, and I think that's a real credit to Dr. Poole and her team and members of the Prevention Network Action Team. Diagnosis, a key aspect. We already talked about the work that the members of the network have contributed to the Canadian Diagnostic Guidelines. We want to draw your attention to the FASD database, which is a database which was started approximately 5 years ago. It started even before that when Dr. Sterling Claren was the scientific director. But this allows the various diagnostic clinics across the country to input data into a centralized, anonymized database to allow a greater understanding of the characteristics, some of the risk factors, some of the neurobehavioral domains that are affected by individuals with FASD. It's the largest and the most comprehensive database in the world, to my knowledge. And in January of this year, I'm sorry, that's the most recent update I have, there were almost 2,500 records in the database. 62% of those individuals had been diagnosed with FASD. So these are all individuals that were seen at the diagnostic clinics. The records from individuals in 7 provinces and territories. The median age of individuals was 12 years, so it's not confined to just children. It does include some adults. But notably, there were no sentinel features present in 53% of those individuals that were diagnosed with FASD. So much really confirming, I think, what we see clinically, but also allowing a greater understanding of how one can develop particular targeted interventions to help individuals and families with FASD. From the intervention perspective, I want to just draw your attention to the framework that Dr. Jackie Pai at the University of Alberta and her team have established and created. It's called Towards Healthy Outcomes for Individuals with FASD. There are 3 major criteria, major approaches used in this approach. The first one being that uses a developmental lifespan perspective, and I'll come back to that on this slide. Recognizes that interventions work in interactive systems, so they're not individual linear relationships, and also that they are strength-based and empowered, so recognizing the strengths of individuals with FASD and those around them. So some of the key characteristics from the developmental lifespan perspective are that individuals grow and they change over time. Goals are uniquely based on individual strengths and challenges. That an individual's past and future impact their functioning, and that intervention is a lifelong process. So again, if you look at the left-hand side in this figure, you can see that from the time of birth, at the lower part of the figure, and then developing up into older adulthood, that there are a range of different aspects of functioning where interventions can be considered through that developmental trajectory. So going from physical health attachment, family cohesion, social functioning, mental health and regulation, education, identity development, community engagement, adaptive skills, housing, employment, and parenting skills. So for each of these, there are specific interventions, and some of those have been established, and there's been a lot of research done on them. So for example, mental health and regulation, just as one example. And for more details on this framework, I would encourage you to look at the CanFASD website. In the field of justice, there's been a fair amount of work that's been done on the prevalence in the criminal justice system, diagnosis and corrections, the cost, both financial, but also the human cost into society, knowledge and awareness among justice professionals, having a better understanding of that, and then developing targeted training programs with various important implications for policy and practice. In child welfare, Dr. Dorothy Badri at the University of Calgary has been a key leader in this area, both nationally and internationally. And areas of research include the importance of early diagnosis, developing interventions and supports, supporting caregivers, being involved in understanding the engagement with other systems, and in particularly with the recognition of historical trauma, which I think we all recognize as a key factor. And as I mentioned earlier, biological mechanisms where how that can develop. One of the key, and I think unique aspects and one of the key benefits of the Canada FASD Research Network is the Family Advisory Committee, or FAC. And this is a group of committed parents and caregivers of individuals with FASD who are interested in how FASD research can improve the quality of life for individuals with FASD and their caregivers. And I suspect that many of you that are listening today would be in that category of groups of committed parents and caregivers with that same desire to improve the quality of life for individuals and their loved ones with FASD. So there are representatives from each of the jurisdictions on the FAC. And their mission is to advise on research priorities for families that are impacted by FASD and to assist in translating the results of research to ensure that they are accessible to families. I had the privilege of helping to organize a research workshop back in 2016. It was partially funded by the Canadian Institutes of Health Research. There were 61 participants. A picture of some of these are here, and some of you will recognize some of those faces as some of the research leads and also members of the faculty or the Family Advisory Committee. Of note is that there were 4 main research priorities that were identified, and those included aging and transitions, advocating for supports, strategies and supports, and FASD as a whole body disorder. So beyond just a neurobehavioral condition, and I think this confirms the findings of some of our adult individuals, the very active and creative groups of individuals with FASD across our country who have recognized these importance of the FASD as a whole body disorder. And with that regards, recently CanFASD has established what is called the Adult FASD Expert Collaboration Team, or AFECT. And this was developed to make sure the voices of those with FASD are included in the research process. It's a group of adults with FASD across Canada who meet monthly with CanFASD members and to talk about FASD research. And each AFECT member is supported by a mentor from the Family Advisory Committee. And I can assure you that from the board's perspective, this group of individuals is already making a significant impact on the direction of research and how that is carried out. So in conclusion, obviously I've not been able to talk about all FASD research, either in Canada or worldwide. But I hope that I've been able to give you a flavor of some of the research that has gone on in the past and also what's going on with CanFASD. There are over 50 research projects ongoing that CanFASD researchers are involved with. There are 9 research leads and research associates. There is the jurisdictional and the individual membership, which I just mentioned, and more information can be seen on the website, which is shown here. And I'd like to just end by saying that I guess by the time we're listening to this, it'll be 2 days before our federal election. And would encourage each of you to think about what you can do to encourage our federal politicians to recognize the importance of creating a national FASD strategy so that we can have common approaches, common understandings, and learn from each other's experiences, both good and potentially not as good across the country. So with that, I'll finish, and thank you very much for listening.